The following podcast is part of a certified educational activity. Access the entire activity and complete the post-test at peerview.com/JGK860. Downloadable slides and practice aids are also available. Thank you for listening to PeerView Podcasts. We greatly appreciate your support and would like to hear from you. Can we ask for a favor? Participate today in a short 1-minute survey at www.peerview.com/podcast survey to share how podcasts play a role in your medical education routine. Again, that's www.peerview.com/podcast survey to participate. And now, on to today's podcast.
Hello, I'm Dr. Richard Isaacson, Director of the Alzheimer's Prevention Clinic at Weill Cornell Medicine, New York Presbyterian. I'm also an Associate Professor of Neurology and Assistant Dean in the Office of Faculty at Weill Cornell. I'm joined today by my colleague, Dr. Soren Matke. He's the Director of the Center for Improving Chronic Illness Care at the University of Southern California in Los Angeles, California. Welcome to this program entitled Advances in the Treatment of Alzheimer's Disease, Preparing for a Shift in the Treatment Paradigm. Okay, let's get started. So let's begin by talking about the evolving best practices in Alzheimer's disease screening and diagnosis. As most of us are aware, there is an absolutely growing healthcare burden of Alzheimer's disease throughout our country and throughout our world. Dementia is by far one of the largest healthcare crises of the 21st century. Believe it or not, there's over 15 million people currently living with dementia worldwide. And this number is set to triple by the year 2050, and this is due to an aging population across the globe. Alzheimer's disease is by far the most common form of dementia, at least 60 to 70% of the cases. And honestly, it's such a costly disease. We know how terrible it is on patients and their family members, but it's also such a healthcare crisis because of the cost on our healthcare system. Believe it or not, between healthcare costs directly, long-term care, hospice support, for example, in patients, and family members, there's a cost of over $300 billion alone in the United States, and this is set to increase to more than $1.1 trillion by 2050. So when it comes to Alzheimer's disease, we're going to talk about some exciting advances in the field. But one of the major advances actually is understanding risk factors and understanding that based on the latest data, 1 out of every 3, possibly even 4 out of every 10 cases of Alzheimer's disease may be preventable if that person does everything right. Now, of course, we can't prevent it or delay in all cases, but through very specific modifiable risk factors, the Lancet Commission 2020 actually has come out with a very profound statement that 4 out of every 10 cases may be preventable. We know about non-modifiable risk factors. By far, the number one risk factor for Alzheimer's disease is advancing age. Having a family history also increases risk. Certain past medical problems, level of education that's low when someone is growing up also impacts risk. Head trauma, loss of sense of smell could be a risk. But when it comes to modifiable risk factors, this is some of the most exciting areas of our research and of our field. Dietary patterns, when I was in medical school, we weren't taught that you could change what you eat to have an impact on brain and cognitive health, but now we know that's the case, especially the Mediterranean style diet. Physical exercise has an impact on a host of chronic medical conditions, especially Alzheimer's disease dementia. Keeping cognitively engaged, modulating one's sleep, staying socially engaged, minimizing stress, and by far, some of the most important aspects of protecting against Alzheimer's disease risk is modifying cardiovascular disease risk factors, like high blood pressure, tobacco abuse, high cholesterol, diabetes. Just having diabetes alone doubles the likelihood of Alzheimer's disease. So these are important factors as we think about emerging areas of treatment. So let's transition and talk about the current diagnostic guidelines for Alzheimer's disease. Back in 2011, the latest criteria really showed that Alzheimer's disease is a spectrum that develops over decades. Honestly, again, over decades. The preclinical phase, or stage 1, is when there are brain changes, amyloid, that is actually building up in the brain silently, literally decades before the first symptom of memory loss begins. And most people are unaware that there are over 46 million Americans today that have Alzheimer's beginning silently in their brain, but no symptoms. So very important, and this is an important avenue for secondary prevention of dementia. When it comes to mild cognitive impairment due to Alzheimer's disease, this is really the first symptomatic stage of Alzheimer's. MCI due to AD is marked by memory changes in other cognitive skills, but they don't impact activities of daily living. From a neuropsychological perspective, someone may take a test and they may have a 1.5 standard deviation below the expected in terms of cognitive function. So that may be a clue to MCI, but they can again take care of themselves. But Alzheimer's dementia, the dementia phase, stage 3, is honestly when they no longer can take care of themselves because of their cognitive deficits. And this is where most of the emphasis of treatments have really fallen. So many people are, again, unaware that Alzheimer's disease begins in the brain literally decades before symptoms. So if we think about Alzheimer's disease as an older person's disease, where if at age 85, that means 45% of people have Alzheimer's disease, that disease first started in their brains between the ages of 55 and 65. And if we move the spectrum even earlier, so if at age 65, let's say 10% or so of people have Alzheimer's disease, well, that disease first started in their brains at the ages of 35 to 45. So it's important to make a distinction between the clinical case and the neuropathological disease characteristics. We know in the clinic that Alzheimer's disease is a progressive neurological disorder where short-term memory gets impaired and other memory and thinking skills go along with it, as well as psychiatric complaints, changes in behaviors, and changes in sleep. But underlying this are neuropathological features, the loss of neurons, the presence of A-beta or amyloid beta plaques, the sticky plaques that get built up in the brain of a person with Alzheimer's. Again, this happens over a decade or more before the first symptom of memory loss. There's also something called intracellular neurofibrillary tangles, or really tau tangles is how they're called. And these are really formed by this abnormal accumulation of hyperphosphorylated tau. So these are the pathological characteristics that really correlate with disease and decline. So the duration of preclinical AD stage 1 can vary, but maybe 6 to 10 years or so on average, depending on the age of onset and the individual person. Over time, patients progress. They progress to mild cognitive impairment due to AD, and then they additionally will, of course, invariably basically progress to the phase of dementia, where the person will need assistance with their activities of daily living. We understand that this is the background. We understand that this is the disease course, but do most of us truly understand that how important it is to try to identify patients earlier in the disease course? Because if we start earlier, then we can tailor therapies as soon as possible, before the horse is out of the barn, so to speak, before the pathology has accumulated so much that the person is experiencing dementia. So what can we do about early identification? Why does it help? Well, early identification is necessary because we can do something about it. And disease-modifying therapies, as they're released, the earlier we start, based on some of the emerging evidence, suggests that maybe the better they work. So the early and accurate detection of Alzheimer's disease-associated symptoms by clinicians, particularly in primary care settings as well as specialists, is important. But that being said, it's extremely challenging. Moving forward, it's essential that the diagnosis of Alzheimer's disease is no longer based on exclusion, but one of inclusion. And what I mean by that is we can encourage clinicians to utilize all of the new exciting diagnostics out there, from structural imaging to biomarkers, both biomarkers in the spinal fluid, in the brain, as well as advancing some of the most recent advances is in the serum or the blood. So let's talk about early signs and symptoms of Alzheimer's. You may be aware of this. Primary care physicians are most likely to be the first clinicians to see and evaluate a person with symptoms related to Alzheimer's disease. Unfortunately, these symptoms are insidious. They're variable in terms of their emergence of symptoms, and it's associated with other dementias. There's other dementias that are related to Alzheimer's in some ways and different in other ways. So honestly, making a diagnosis can be challenging. The other challenging part is primary care doctors, especially, with the boots on the ground, treating a large volume of patients, as well as neurologists, psychiatrists, geriatricians, geriatric psychiatrists. We just don't get the amount of time we need to spend with patients. Our medical health system is challenging, I'll put it that way, and getting 15 minutes or 20 minutes or 30 minutes even to spend with a patient just doesn't do it in terms of being able to make a qualified diagnosis. Although the symptoms are variable, progressive short-term memory loss is really a hallmark psychological concerns, depression. Also, some of these symptoms may be mild or subtle. And also these unusual behavioral changes are also something really important to consider. So how do we make a diagnosis of Alzheimer's disease? Let's talk about the role of caregivers, because a person may come presenting with symptoms, and that's all well and good, and that's helpful, but getting that additional corroborative history from a caregiver, from a loved one that spends, at least 5 to 10 hours a week with the patient is especially helpful. Getting a family member involved, a friend even, if a family member isn't available. Understanding that patients may often avoid making an appointment until their symptoms significantly affect their daily lives, and also because of so much stigma. Alzheimer's is such a stigmatized disease. We don't want to talk about Alzheimer's disease. We want to hide away from it and shy away from it. And honestly, that's the worst thing we can do, because the earlier we treat, the earlier we realize something could be going on. I really believe, and I think the evidence is emerging, that we can do something earlier, the patient will do better. So retrieving information from a caregiver or a loved one or a friend is essential, both when trying to assess a patient and also really trying to delve into what their daily routine is, what their mood and behavior truly is, what their sleep patterns are, and honestly, what's changed over time. An important question we often ask patients is, how is your memory now compared to what it was a few years ago or 5 or 10 years ago? And some of the best insight to that can come from a caregiver or a loved one. Also, it's essential to have a caregiver or a friend or someone. And a caregiver, the term caregiver can involve a wide range of a definition, but understanding that having someone to help through the diagnostic pathway, the clinician can really rely on this person to provide support, to provide not just psychological support, but maybe logistical support. There's a lot of appointments and evaluations and blood tests and maybe a PET scan or maybe a spinal fluid test, or who knows, all the different types of things. You need to be, arranged appointments to get neuropsychological testing. There's just so many different aspects through the diagnostic process. It can be challenging and stressful enough for the patient. So it's really important that we have someone kind of helping along the way. So let's transition and talk a little bit about some of the most useful diagnostic biomarkers for Alzheimer's disease. Some of the potential biomarkers for functional impairment, neuronal loss, and protein deposition that can be useful, and that are now actually relatively available, include amyloid PET, which is a PET scan, a positron emission tomography that includes amyloid as a tracer. Structural MRI. Structural MRI is basically an MRI of the brain to see if there's been shrinkage in specific areas related to Alzheimer's disease pathology, something we use all the time as first line. FDG or glucose PET scanning can also label glucose, and if there's low glucose metabolism in regions that are specific for Alzheimer's disease decline, that can absolutely be suggestive of Alzheimer's pathology. And then some more invasive tests, but very helpful. In Europe, these are used frequently. In the United States, maybe a little less common. But spinal fluid tests, looking at plasma A-beta-42 to A-beta-40 ratio, as well as looking at p-tau, phospho-tau, and total tau in the spinal fluid, and looking at a signature of these. And there's also other emerging markers, which we'll touch on briefly, including serum markers like p-tau217, which is elevated in the blood years and years before a person develops dementia. So it can be a really helpful screening tool. Maybe not perfect yet, but helpful. Something that's really important that's a little bit newer is the Atn Framework. This was just published a couple of years ago, back in 2018. And this is a guide for describing biomarkers in terms of a framework of a kind of a biological construct of Alzheimer's disease. So the A stands for aggregated A-beta or associated pathologic states. And we talked earlier about you can do an amyloid PET scan, you can look for amyloid in the spinal fluid. Also, the T stands for aggregated tau, again, neurofibrillary tangles. Spinal fluid can assess for tau, phosphorylated tau, and total tau, and also tau PET. Just recently, even tau PET has kind of come along the horizon, or just being able to be ordered pretty soon, and even now by clinicians. And then finally, neurodegeneration or neuronal injury. Anatomic MRI, structural MRI can view this. FDG PET, glucose hypometabolism, again, can show signs of neurodegeneration when the brain cells aren't firing and there's less metabolism, metabolic activity. We can really detect this on even just glucose PET scans. And then finally, spinal fluid total tau is also a marker of neuronal injury. So transitioning, what can we do now? Well, clinicians can really order an imaging protocol, and based on American Academy of Neurology guidelines, in the workup of a person with suspected Alzheimer's disease or other dementia, we have to order some brain imaging scan. And in the guidelines, it says CAT scan or MRI, but from my own personal clinical experience, we really advocate for MRI, and we order it a specific way with thin coronal cuts through the hippocampus or through the temporal lobes to assess for is there hippocampal atrophy. You can even ask the radiologist to say, is there atrophy? Is there global atrophy? Is there frontal, temporal, parietal atrophy? And depending on the pattern of shrinkage of the brain, and especially shrinkage in the hippocampus, the memory center in the brain, which is deep down in the temporal lobes, we can make a pretty reasonable ascertainment about what the person's diagnosis could be, in addition to a comprehensive clinical history. When it comes to positron emission tomography, over the last eight or more years, we've now had FDA-approved imaging agents from using different amyloid labeling agents, and this really estimates the amount of beta-amyloid plaque in the brain. When it comes to amyloid PET is actually the only imaging modality currently recommended by the Alzheimer's Association and the Amyloid Imaging Task Force to support the diagnosis of Alzheimer's. I think really a clinician has to decide what works for them in their practice environment and based on their clinical suspicion. Many clinicians that I work closely with actually like just as much or even prefer spinal fluid tests. It's less costly, although it is more invasive. Some of my colleagues actually really believe well in FDG PET, looking at glucose hypometabolism, which in the setting of a progressive cognitive decline that looks like Alzheimer's, progressive short-term memory loss, a positive PET scan using glucose is reasonable as well. However, an amyloid PET may be the gold standard in some environments. And again, it utilizes tracers that can bind to A-beta, and a positive amyloid really strongly predicts the presence of A-beta, but a positive amyloid PET scan also does not definitively diagnose Alzheimer's. There are lots of people out there, possibly up to a third of cases that may have amyloid in their brain but won't develop dementia. And this is really important and a little bit of a confusing topic. Amyloid PET's also quite expensive. It's not reimbursed by insurance, and maybe the landscape will change, but currently it has not. When it comes to spinal fluid biomarkers, believe it or not, spinal fluid biomarkers can be detected in the fluid at least 15 to 20 years before the onset of symptoms. We alluded to this earlier, but there's kind of a signature that we look for between the presence of A-beta 42 as well as p-tau and total tau, t-tau. And this signature together really can impact our decision tree about whether or not the person could have a pathologically defined Alzheimer's disease case rather than something else. Decreased spinal fluid A-beta 42 basically suggests that there's increase in the brain. So it's a little counterintuitive, but in the spinal fluid, a decreased A-beta 42 and an increased tau isoforms are suggestive of Alzheimer's disease dementia rather than something else. And you can use these really ratios to dive down deeper. Alzheimer's disease is certainly associated with these markers, but it's important to just kind of understand these markers just a little bit better. P-tau can provide a direct measure of the amount of hyperphosphorylated tau in the brain. It can also be suggestive for the presence of neurofibrillary tangles. Now, t-tau can also be used to predict the level of neurodegeneration, but t-tau is also increased in other neurological conditions, so things get a little confusing here. So the progress that we've made in biomarker development has been striking. There's now blood-based biomarkers, and again, this is not ready for prime time just yet, but in a few years, it's going to be exciting. And I honestly think that within a few years, at least one or two of these markers will be available commercially, and we'll be able to inform our care. I think probably some of the most press, most excitement has been on p-tau 217 as well as p-tau 181. There are several p-tau isoforms that can truly give a clue that something is brewing and that Alzheimer's dementia may be on the horizon. So to wrap up, we've talked about a lot of exciting things. We've talked about anywhere from risk reduction and exciting things on the horizon there. We've talked about diagnostic modalities, some that are available now like MRI and others that will be available in the future like serum. But some things that we can do every day in clinical practice. There's so many things actually. So I want to end with talking about how today we can do a very reasonably well-constructed clinical evaluation for a person with memory loss symptoms in practice. So number one, a detailed clinical history. Just to be honest, neurologists, this is how we go. This is how we do it. This is how we make diagnoses. 80 to 90% of the time in neurology, a diagnosis, could or should be made based on the history alone. Now with Alzheimer's disease, getting a biomarker is certainly much more definitive, but in the absence of the availability of biomarkers, we can make reasonable estimates as long as we take a detailed clinical history, understanding what the family history is, understanding the changes in cognition over time, understanding whether there may be some non-cognitive symptoms that are related to Alzheimer's disease. These are really critical, and doing a detailed clinical history is critical. Neuropsychological testing also essential. In our office, sure we can do a variety of screening tests, but kind of the gold standard is sending someone for more full neuropsychological testing. And I think on the horizon there's going to be computer-based tests that we use, online tests, and some practitioners out there, in our practice, we actually have patients do an online battery before they even walk in the door, so that we can get a nice, at least introductory overview, and then we can send someone for a more gold standard neuropsychological evaluation afterward. In terms of laboratory testing, kind of the routine stuff, checking for a B12 deficiency, hypothyroidism, these are things that certainly come up 5% of the time, 7% of the time. They also may come up abnormal in a person with Alzheimer's disease, early AD. So it's important to screen. It's important to try to make a reversible causes of dementia workup. But again, a lot of the times we're not going to find that. And then while genetic testing is controversial, I'm a big personal believer in ApoE. ApoE4, for example, is a variant that increases Alzheimer's disease risk. If you have two copies, two variants, one from mom, one from dad, it increases your risk even more. I don't use ApoE for a diagnostic test. I don't believe that it's diagnostic at all. You can have an E4 variant and never get Alzheimer's. You can not have an E4 variant and absolutely get Alzheimer's. But it's in some ways helpful in some ways because I use it to personalize care. And the future of Alzheimer's disease treatment and prevention is precision medicine and personalizing care based on ApoE, based on a variety of other individual patient characteristics, other genes that we may test for more in the future. I really believe that precision medicine and personalized medicine is the future, and ApoE, in my opinion, anyway, does play a potential role. Let's talk about the evolving treatment landscape in Alzheimer's disease and the practice-changing implications of disease-modifying therapy. So currently, what is our treatment landscape? In clinical practice today, where are we? What can we do now? And where are we going in the future? What are the limitations of the available treatment regimens? Well, there's several, but there is absolutely something anyone can do today to try to make an impact. So let's first talk about the current FDA-approved treatments for Alzheimer's disease dementia. Now, this includes mild, moderate, and severe Alzheimer's disease. Earlier, we were talking about preclinical disease, mild cognitive impairment due to Alzheimer's disease, stage 1 and stage 2. We don't have any current FDA-approved therapies, but there are some potentially on the horizon. When it comes to the treatment of stage 3, mild, moderate, and severe Alzheimer's disease, let's talk about the 4 FDA-approved drugs. The take-home point with these drugs to really have some best practices is to start low and go slow. There's no reason to hit someone hard with a high dose of a medication that can cause side effects, especially some of the GI side effects that can be common with these meds if started at a high dose and if started in a suboptimal way. Start low and go slow. Rome wasn't built in a day. The slower we go, the more likely a patient is to tolerate. If a patient is able to tolerate, the better the patient will do. Now, these drugs are not miracle drugs. They can have some modest alleviation of symptoms. They also can work differently in different people. And, for reasons that go beyond the scope of this discussion, maybe somewhat grounded in precision medicine, maybe somewhat grounded in if the person has other markers or other medical comorbidities, if the person is engaging in other activities to try to make those drugs work better for them. What I can say is that there isn't a stereotypical response to these drugs. Some people improve for a short while, some people stabilize, and other people will decline no matter what you do. Also, these drugs, the FDA-approved drugs currently, do not prevent disease progression. That's really important to know. They're not disease modifying. But again, symptomatic therapy is better than nothing. When it comes to acetylcholinesterase inhibitors and Memantine, which is an NMDA antagonist medication, these have been shown in multiple studies and even meta-analyses, which we'll talk about, to have consistent effects in domains of cognition, as well as global assessments. When it comes to augmenting the effects of cholinesterase inhibitors, well, we all know about Memantine. Memantine is approved by the FDA for moderate to severe Alzheimer's in combination with a cholinesterase inhibitor. It's not really approved for first-line care. But when it comes to cholinesterase inhibitors, maybe another way that I think most people may be unaware of is a study from just over a decade ago looking at can cholinesterase inhibitors be augmented by the use of folic acid. And there was actually a randomized study. It was a small study, but it was an important one, showing that 70% of patients that received folic acid plus a cholinesterase inhibitor versus just 39% of placebo subjects were classified as responders. So take-home point here is, again, the devil is in the details. Maybe we don't have all the information we need yet to truly understand who may or may not respond to these therapies. But in my clinical practice, if it's evidence-based and safe, we try it. We use cholinesterase inhibitors first. We may add B-complex vitamins, especially depending on the individual person, especially if they have an elevated homocysteine level, which is a marker in the blood. And it's a study called the Vitacog Study, which is an interesting study looking at people with mild memory complaints, and B-complex vitamins helped only if you had elevated homocysteine. It helped to maybe improve memory a little bit and also delay brain shrinkage. So when you add the B-complex vitamins, the cholinesterase inhibitors, the Memantine, when you have already transferred into this moderate to severe stage, plus you get control of the vascular risk factors and maybe do other non-pharmacological interventions, adequate nutrition, for example. These are the types of comprehensive care models that I think may be best served for treating a patient with Alzheimer's disease. When it comes to the clinical pipeline of Alzheimer's disease and disease-modifying therapies in development, this is just some really exciting stuff. We're not there yet. We've made a lot of progress for sure, but I think the next 5 to 10 years is going to be hopefully a kind of a precipice in our field of Alzheimer's disease care. When it comes to disease-modulating therapies that are in development, there's a lot. There's many. Anti-A-beta monoclonal antibodies, we'll focus on those today. Aducanumab, gantenerumab, and BAN2401. BACE inhibitors have also received a lot of attention. However, there's been a lot of failures and even some side effects. So some of these have fallen out of favor. Tau vaccines are being studied, anti-tau antibodies, and then, of course, other pathways too, from the glucose hypometabolism pathways, TREM2. There's a lot of potential therapies out there, from amyloid to tau to oxidative stress and mitochondrial dysfunction. There's just so many that we can attack. Inflammation, infection. I really think that in the next 5 to 10 years, this is going to be a whole new landscape when it comes to Alzheimer's disease therapies. So there's multiple therapeutic targets that are under investigation. This is a nice diagram I like because it shows kind of how the amyloid pathway is complicated. Again, it's not one size fits all. ApoE, the ApoE4 variant, the most common genetic risk factor for Alzheimer's disease, can lead to accelerated amyloid. It can lead to potentially tau pathology or neuronal loss, or is associated with inflammation. We're not really sure. Could be related to clearance mechanisms, synaptic dysfunction. And then, of course, when we use things like BACE inhibition or gamma secretase inhibitors to try to intervene in that way, there's so many different ways to try to attack the amyloid hypothesis, from reducing amyloid plaques, addressing toxic A-beta oligomers, addressing A-beta-42 monomers, and really the devil again is in the details. We've had a lot of failures in Alzheimer's disease and even in these anti-amyloid therapies, but the devil is in the details. Maybe we need to attack one aspect versus another, and that's why the initial studies failed. This is a nice example of some beta-amyloid-related disease-modifying strategies. And again, there's lots of different ways to intervene, lots of different ways to fry an egg, some people say. I think what we need to do is figure out of these different strategies which may have the most benefit and in which specific people. Again, this precision medicine aspect is key. So we'll talk about one of the more exciting therapies, aducanumab, which has recently been, really the studies have been completed and the FDA has now been actively reviewing. And aducanumab is a human recombinant monoclonal antibody that's in development for Alzheimer's. It's derived from de-identified library of B cells that are collected from healthy elderly subjects. with no signs of cognitive impairment or cognitively impaired elderly subjects with unusually slow cognitive decline. So kind of the ones that kind of retain their brain health over time. Super agers, some people have called them too. Results from a phase 1b study, which was very exciting, made the cover of one of the major scientific journals. It demonstrated statistically significant reductions in amyloid plaque, and it also showed improvements in the CDR, the Clinical Dementia Rating Scale, sum of boxes, and the mini-mental. And this is critical because in the past, we've had therapies that have reduced amyloid in the brain. Great, the pictures look better, we feel good about things, we have target engagement, that means we're making progress, but it hasn't also improved outcomes. So in this case, cognitive outcomes and functional outcomes. The CDR sum of box is a rater given. An investigator like me would ask the questions to the patient and caregiver, for example, and we'd really understand what their function is like. So the fact that the initial study showed improvements in cognition and function, as well as target engagement, reducing amyloid in the brain, was pretty exciting. When it comes to the monoclonal antibody, it was then evaluated in two global phase 3 studies, Engage and Emerge. These are designed to evaluate the safety and efficacy in slowing cognitive impairment and the progression of disability. And also looked at function. Function is key, not just how someone does in the cognitive test, which may or may not be kind of clinically relevant, but how a person does with the earliest phases of Alzheimer's disease. And briefly, I won't go into too much detail, but the phase 1b study results, I had a few patients in this study, really showed that we had target engagement, and honestly at the highest dose. So here again, this is why we do early phase studies, to truly understand maybe the 10 milligram per kilogram dose once a month was the better dose, because at lower doses we just didn't see much with changes in amyloid in the brain, and it also didn't really see much with the clinical outcomes as well. However, there was some increase in side effects. So side effects is ARIA. We'll talk about that a little bit later, but ARIA is an important amyloid-relating imaging abnormality is what ARIA stands for. And it's important because these are things we need to track in our patients, and it showed that patients with at least one copy or one variant of the ApoE4 allele, those patients had a higher likelihood of developing this side effect. Now, it's an imaging side effect. It doesn't always lead to symptoms, and oftentimes it actually doesn't lead to much at all, and people get better. But again, it's something important for fair balance to talk about these potential adverse events. When it comes to phase 3 Emerge and Engage trial, this was a very confusing study because we had two concurrently run, one failed and one looked more positive. So when it comes to the twists and turns of the aducanumab story, in October 2019, the company actually announced that there was a larger data set. Initially, the studies were stopped due to futility analyses and other issues, and then all of a sudden, the company announced that from a larger data set showed that Emerge actually met its primary endpoint, and as we just talked about, change from baseline in the CDR sum of boxes. And this is an exciting and important number to move, because if you can demonstrate improvements in functional outcomes, well, that's important. That's real world. That's important. Doing a little bit better on a cognitive test, sure. Reducing amyloid in the brain, sure. Those are all important in one way. But honestly, if you can truly improve outcomes, quality of life outcomes especially, these are the types of things that are exciting. And in this study, there was, in the pooled analysis, there was less decline on secondary endpoints at the highest dose, the 10 milligram per kilogram dose. So while the Engage study did not meet its primary endpoint, the subgroup analysis also showed that patients on the highest dose showed a similar response as patients in the Emerge study. And based on these data, the company did apply for FDA approval. When it comes to additional emerging therapies, I wish we had more time because there's a lot. BAN2401 is a humanized monoclonal antibody. Its mechanism of action binds to high affinity, to aggregated A beta, and there's lower affinity for monomers. And it demonstrates, the ability to remove amyloid from the brains by PET scan. And again, this gets back to that image we showed earlier, that maybe monomers wasn't the answer, even though we initially focused on that in other other molecules and other trials, but maybe this aggregated A beta is what we should have been is going for all the time. A large phase 2 trial also had a patient or two in there with early AD. Actually, I had several patients in there, and that was exciting because it showed significant efficacy at 10 milligrams per kilogram IV, although this was given twice a month, so a little bit more frequent. And there's a new study ongoing now, a phase 3 study, going to enroll just over 1,500 subjects with early AD, and they're going to look for kind of a similar outcome, the change from baseline in the CDR sum of boxes at 18 months, and hopefully we'll have some readouts of that, in the next maybe year and a half or so. When it comes to band 2401, there was slowed cognitive decline, and it was dose dependent. Again, this is important to understand. Dose dependent reduction in decline on the ADAS-Cog, that's the cognitive measure. This dose dependent change actually started at 6 months, and that may have been reassuring too. This is kind of where we need to go. We need to keep going and trying, and from every failed study we learn something new. We learn maybe how to dose it, what dose to use, what patients to recruit. The initial anti-amyloid studies that we did over a decade ago, we didn't even do amyloid scans. We didn't even know that they had amyloid in the brain, and some studies didn't even have people with amyloid. 20, 30, 40% of people in the study didn't even have amyloid. But we found that out later. So the key here is when you keep iterating and you keep trying different pathways and different mechanisms, there is more likelihood for success. Gantenerumab is also another potential treatment that's shown dose-dependent decreases in amyloid after a while of treatment. Again, you've heard this before, we're trying to find the right dose, the right timing, how long do you need it for, and I think gantenerumab is going to be another exciting therapy out there that we just, again, need to collect more data on in trials. So what have we learned? When it comes to anti-amyloid antibody trials, I guess what I would say is the effects may be larger in mild stage, very mild, or MCI stages than moderate stage Alzheimer's, and really there's been no signal seen in the more advanced cases of moderate stage or more advanced. Data suggests that dose adjustments in E4 positive patients, E4 carriers, may be important to reduce the likelihood of side effects and also maybe maximize the potential for therapeutic benefits. There's several ongoing phase 3 trials that will hopefully give us some more clarity on this. And then increasingly, these immunotherapy trials are looking to intervene at earlier stages. If we can, again, intervene early, if we can arrest or delay disease progression, maybe we can prevent or delay the progression to dementia. We talked about ARIA earlier, and these are white matter lesions that may or may not have some edema, some swelling by brain imaging. There's the E version, which is E meaning edema, vasogenic edema, and then there's the H version, which is more microhemorrhages or hemosiderosis. They typically resolve. Their presence, honestly, is not always associated with symptoms. They're primarily, in my opinion, and based on some of the data, a function of whether or not a person has the ApoE4 variant and higher doses of the therapy. So it's something to watch for, it's something to take seriously, but it's something where we don't have to get, in my clinical experience and with patients that have had this in a variety of trials, I don't think we need to worry in terms of a catastrophic event. Now, the beta and gamma secretase inhibitor story is a long one. There's, several, unfortunately, especially gamma secretase inhibitors have failed. Beta secretase inhibitors, BACE inhibitors have also failed. And I guess what I would say is there's some interest and there's was some excitement, but I think we need more research to truly understand if these are going to be a plausible therapeutic target. Tau is also something that's exciting when targeting amyloid has not succeeded, because amyloid does not exactly correlate with progression of clinical disease, but tau tangles do correlate well with clinical progression. There are now multiple targets against tau, lots of immunotherapies under investigation, active and passive approaches, and I think this is exciting. Can we prevent tau aggregation? Can we stabilize microtubules? Can we block tau from forming? I mean, these are important clinical questions. The future of Alzheimer's is not just treatment and prevention of dementia, but maybe prevention of the disease altogether, and also prevention of dementia in tune together. The A4 study used solanezumab for people that had positive PETs but no or really minimal cognitive complaints, ages 65 and 85. The study is now closed, and hopefully we'll have some data on this in the coming year. The Tomorrow study was also an interesting, very exciting study where it used a genetic screening to really personalize care using a low-dose diabetes medicine in a very specific cohort. Unfortunately, that study failed, but there could be a lot of reasons for that. Did they not pick the right patients? Was the outcome measure not really the best outcome? The outcome measure was actually conversion to mild cognitive impairment due to AD, and there was 3,500 patients in the trial, a large study, but it's just the futility analysis just didn't pan out. Maybe they needed another analysis. Maybe they needed another dose. They used pioglitazone at a very low dose in effort to reduce likelihood of side effects, but this unfortunately did not pan out. The Diane-2 study unfortunately recently failed, but there's some exciting studies going on. A345 for A3 for primary prevention, A45 for secondary. The Alzheimer's disease prevention initiative studies, the API studies are also exciting, and hopefully we'll have some readouts in the coming years. When it comes to randomized trials and pre-symptomatic AD, there's lots, and I think the devil again is in the details. The AHEAD study, ADCS AHEAD, which is the A3 and A45 study, is going to be using band 2401, and really excited to see if we can really move the needle in preclinical AD and even primary prevention. But to end, I think we have a lot of excitement when it comes to the pharmacologic therapies, but I absolutely have to put some credence to the really impressive evidence now that's evolved for non-pharmacological interventions in early stage disease, from the multi-domain intervention study, the FINGER trial, to studies done with just physical exercise and mild cognitive impairment, a cognition-based intervention. Our work in the Alzheimer's Prevention Clinic, where we use multi-domain, comprehensive, individualized care in our program. We gave people up to, on average, 21 different interventions based on their individual risks, and showed that, people with MCI, if you followed greater than 60% of the recommendations, they actually had better cognitive function at 18 months than they did at baseline. And these are, all of these studies taken in context, I think really show that the earlier we intervene and the more we do, the better off we are. Okay, now you will hear from Soren about how we can prepare for the arrival of a disease-modifying treatment for Alzheimer's disease, so that patients are able to access these therapies in a timely manner once they become available.
Thank you, Richard. It's a pleasure to be here. My name is Soren Matke, and I'm a professor of economics and the director of the Center for Improving Chronic Illness Care at the University of Southern California in Los Angeles. As Richard mentioned, today I will speak to you about the need to prepare for a surge of patients once a disease-modifying Alzheimer's treatment is approved and becomes available. As you know, we are getting close to the first disease-modifying treatment for Alzheimer's disease. The FDA will decide on the approval of aducanumab by March 7, 2021, and we have an advisory committee scheduled on November 6 this year. This would be a breakthrough after decades of failed trials in Alzheimer's disease that could give new hopes to patients and their families. The treatment would have to be used in the early stages of the disease and reduce progression of the disease. And this preventive approach is necessary because neuron loss cannot be reversed. So we need to prevent progression. i.e. we need to identify patients at the stage of MCI or mild dementia due to Alzheimer's disease in order to treat them. So with this potential breakthrough, why am I worried? If you think of it, Alzheimer's disease is enormously common, and because we never had a disease-modifying treatment, we have this large pool of prevalent cases who have never been formally diagnosed, because neither patients nor doctors saw much reason to ascertain the precise nature and state of cognitive decline in the absence of a disease-modifying treatment. So when we have a treatment that's actually specific to one of the many etiologies of cognitive decline, people will seek out evaluation and then subsequent treatment, and the demand for these diagnostic services may overwhelm the capacity that we have in our healthcare system when the treatment becomes first available because of the large prevalent pool of cases. And the reason is this combination of a preventive paradigm for treatment, which usually evokes images of simple and scalable interventions like flu shots and cholesterol-lowering drugs, but in this case entails a highly complex disease process that looks more like high-end oncology care, with biomarkers, complex differential diagnosis, targeted treatment, imaging, and infusion care. So unless we identify and address these capacity constraints in our health system in a timely manner, we may end up with millions of patients on the wait list for diagnostic services. And with this being a progressive neurodegenerative disorder, millions of patients might progress to manifest dementia, a no longer treatable state on those wait lists. And the COVID-19 pandemic has made very clear to us that even sophisticated healthcare systems find it very, very hard to deal with unexpected surges in demand without proper preparation. So let me walk you through a highly stylized patient journey towards a disease-modifying drug. If you have here the transition from prodromal Alzheimer's disease to mild cognitive impairment, somewhere in the middle, patients would seek out an initial screening, probably at primary care settings, which we consider not to be capacity constrained. If they test positive on a simple assessment like the Mini-Mental or MoCA, they would be referred to further evaluation to a specialist for neurocognitive testing to confirm cognitive decline. Then, if confirmed in a treatable stage, biomarker testing, most likely with PET scanning or CSF testing, and then eventually infusion treatment, at least in the case of aducanumab. And then we assume that the treatment reduces the risk or the speed in which patients transition from early stage disease to manifest dementia. All of these steps in the patient journey here, evaluation, testing, and treating, are capacity constrained. So if you look at these numbers, it becomes clear that we have a problem with available capacity. If you consider the 55 plus population in the US, this is the range in which we would start looking for treatment candidates. That's about 90 million people. If we only screen about 80% of them, that's still over 70 million people. And with the performance of the Mini-Mental, you would about have 15 million people screening positive. And even if you only refer half of them, we need about 7.5 million specialist visits to handle all the potential patients in the first year. We would need about 6.7 million PET scans done in those patients in the first year. And we would need about 2.5 million patients in infusion treatment again in this first year. And as you can imagine, these are large cities or small countries, and even a sophisticated and well-resourced healthcare system like the US does not have that capacity available. So this is what we project to be the wait list. This is a 2017 analysis, so we started 2019, and this is going to be the wait list of patients. So we can see that the initial wait list for specialty visits would be about 4.5 million, and then these wait lists, even as we work off first the dementia specialist wait and then the amyloid testing wait, with the treatment being an infusion treatment, you would continue to have wait lists well into the mid-2030s. And the wait would actually be substantial. Here you can see that in the first years, the wait would be on average about 18 months, 1.5 years until we get somebody to treatment. And again, as I said before, the treatment delays decline over time, but they're still present until about 2034. And this matters because we have millions of patients waiting for their treatment, and we have estimated that in this scenario about 2 million patients with MCI, which is a treatable state, could progress to a state of Alzheimer's dementia where treatment is no longer presumed to be effective while on the wait list. 2.1 million patients. And unfortunately, that's not all, because we can expect capacity obstacles beyond capacity in other areas. In the primary care setting, in the memory clinics with biomarker testing, and then even with follow-up after the treatment initiation. So if you look at the primary care challenge, the formal workup of a patient with memory complaint in the primary care setting is covered, but usually what we hear from primary care physicians is that payment is relatively low relative to the required time of effort. As you can imagine, having a conversation with somebody about cognitive decline, potentially involving the family, and potentially involving at least brief cognitive testing, takes way more than the usual 15 to 30 minutes office visit. To make things worse, there is currently no dedicated billing code for a brief test like the Mini-Mental or MoCA. And those take, as you know, about 15 minutes, i.e. they could take up an entire office visit. And then there are considerations of workflow beyond capacity that are problematic, because primary care physicians are very used to a tight scheduling of their day, and they dislike diseases like dementia where visit duration is very unpredictable, because you may have trouble communicating, you may have to involve family members, and it makes it really hard to slot these considerations into the usual day. And then there's a problem with task shifting. Many of the mundane tasks in the primary care office are now handled by primary care providers, but early cognitive decline evaluation is complicated. There could be mixed etiologies, there could be coexisting conditions that either worsen or even cause the cognitive decline, like substance use or mood disorders, and that goes well beyond what a physician assistant or nurse practitioner can usually sort out. And then it's also a matter of capability, because thus far primary care physicians have not focused on cognitive evaluation on a routine basis. So they are not familiar with the tools, they are not familiar with the differential diagnosis of different causes of MCI. And then there's a very arcane problem that I learned, is in that for most electronic health records, they don't even have a coded fields for cognitive tests. So primary care physicians typically have to do the test with pen and paper and then scan it into the EHR to make it available for further evaluation. Even the primary care memory clinics that focus on cognitive decline and dementia will need to shift from their current focus on care to a new focus on cure. If you think of it, outside of the large clinical trial sites in your academic medical centers, most memory clinics today focus on neuropsychological evaluation and then counseling and linking up with social services. So this means these are usually relatively small clinics, and the task shifting mostly occurs to social workers. In a disease-modifying treatment world, you will have to have a medicalized practice model that looks more like your typical MS practices or oncology practices today, with sort of procedure room for CSF retrieval, potentially PET scans on site, infusion delivery. So you need a very different scale and staffing mix in a memory clinic to be a viable site for disease-modifying treatment. And then we have several problems with access to biomarker testing. At the moment, no confirmatory biomarker test in the US is covered for routine clinical use. PET scan, amyloid PET, is currently covered under the IDEA study at a selected number of sites. This is a coverage with evidence development protocol. If the IDEA study shows that even the diagnosis in the absence of a disease-modifying treatment has prognostic implications, CMS might, I emphasize might, cover PET scans for routine use. The CSF biomarker is not even approved in the US. So while the lumbar puncture, of course, is covered as a routine procedure, the test is currently not paid for routine clinical use. And we are still far away from a blood-based test that is not even filed yet in the US. Then there are problems, assuming we get the coverage situation sorted out, that PET capacity is of course limited, and so is the manufacturing of the tracer capacity. So the amyloid ligand is a fairly unstable radiopharmaceutical, and it doesn't travel well. So you have to have not only a PET scan and get time from your oncologists to use it for cognitive decline cases, but you also have to be close enough to a cyclotron to get the tracer over in a reasonable time frame. And then the alternative also doesn't look better, because lumbar puncture has become an uncommon procedure. Of course, US neurologists still know how to do it, but your practice may not be set up and trained for it to assist you, to have the procedure room, the room where a patient can lie down for an hour or two. And so it's done, but it's usually done in neurology clinics or inpatient settings at a fairly small volume. And moreover, patients are quite reluctant to undergo lumbar punctures, especially in Anglo-Saxon countries. This map shows you the problem with access to the amyloid tracer. So we drew a circle around all the cyclotrons in the US that shows roughly the distance, how far the tracer can travel without degrading. And you can see that especially here in the rural West, there are entire states where you couldn't even conduct an amyloid PET, even if you had a PET scanner available. So those patients would have to travel either closer to where the amyloid tracer is manufactured or undergo CSF testing. And coincidentally, these are also the areas in the US where we have a dearth of dementia specialists, what the Alzheimer's Association calls the neurology deserts. It's not all bleak. Here's one technology that can actually resolve many of our problems, and that is a blood-based biomarker test. The elegance of this test, that has now matured from a test that can only be done in highly specialized labs to a test that can be fully automated, is that it gives you at least initial confirmation that a patient has the Alzheimer's pathology. So if you combine that test with a brief cognitive evaluation like the mini-mental, you also get evidence that the patient has a likelihood of cognitive decline, and you can do both of these tests in a primary care setting, i.e. you can triage patients whom you refer to specialists, because you won't refer the false positives who end up not being treatment eligible for the DMT. You primarily refer the ones who are amyloid positive and have suspected cognitive decline. So if you look at this graph here, under the assumption that we would refer to specialists only on the basis of the mini-mental, if we take into account the performance of this test, we would have to refer about 22 million patients. The dashed line here shows you the available specialty visits over the years. So with a mini-mental only, for a very long time, we would have to require more visits than are available, i.e. it's going to be really hard to reduce the backlog. If we add the mini-mental and the blood-based biomarker together, only about 10 million visits are needed initially, and we can work off the backlog rather quickly, so that even within a few years, we fall under the available supply of specialists. This means the introduction of this relatively simple and scalable test is the equivalent of increasing specialist capacity by about 60%, because you as the scarce specialists can focus on the priority cases that are likely to be eligible for treatment. And then there's the issue of follow-up. Of course, patients will require additional visits after treatment initiation to see whether treatment is effective and whether it ought to be continued, and that obviously requires additional specialist time and exacerbates the shortage. We will need to think about patients in chronic MCI. These are not patients that are perfectly healthy. They still have cognitive decline and need support and potential other treatment, and we haven't really thought about the issue of keeping people in that state for a very long time frame. We do need regular MRIs for ARIA as a common complication of amyloid targeting treatments, And while the US has ample capacity, if you look here on the right, compared to other high-income countries, to do MRI scanners, there's actually a shortage of neuroradiologists that are able to read all these scans in a timely fashion. So what does this mean for you as a neurologist? First of all, it is important to educate your referral network. Your primary care physicians, your internal medicine colleagues should really inquire about memory loss actively, especially in elderly patients, and absolutely take subjective memory complaints seriously. The current attitude is often that cognitive decline is an inevitable consequence of aging, and your referral network needs to understand that this is not the case, that these people need to be evaluated and referred for eventual treatment availability. It is also important that primary care physicians would conduct basic testing, like at least a brief cognitive test, depression screening, blood tests for vitamin B12 and thyroid, potentially assessment of substance abuse, so that they identify patients who should not need dementia evaluation early on because they may have a treatable cause of this dementia. In an ideal world, they would also send them to you with structural imaging to rule out focal processes or normal pressure hydrocephalus. And then for your own practice, this means that we need new practice models for memory clinics or entirely new memory clinics that look a lot more like your MS and oncology clinics. And that can be virtual these days, so it doesn't have to be all on site. So you could have a partner imaging site or a unit in a hospital to do CSF testing, so that you don't have to have sort of the physical plan to do it all in one place. But of course, from the patient perspective, it would be preferable to have a one-stop where they can get all services in one building. And you need to keep current on access to biomarker testing, given that regulatory approval and coverage decisions are in flux. And of course, those decisions will determine which of the different tests for triage and also definite diagnosis can be used in routine care. And it's also important that not all of these tests may be available in local facilities, right? Like even if a CSF test gets approved, it is not necessarily the case that the assay is available in your local lab in a short time frame. So why does this matter? Why do we need to think about, even though it is still uncertain that the FDA will say yes to aducanumab? Eventually, I'm convinced we will get a disease-modifying treatment, this or the next one, and they will become progressively better, as we have seen in many other diseases. This is a condition with enormous unmet need. It's one of the last population-level conditions where we really have nothing to modify the course of the disease. And that has devastating consequences to patients, to their families, and of course to society, because we have this tsunami of aging patients that will progress to dementia and will need a lot of care and a lot of resources when we might have a possibility to keep them in a healthy state much longer. And it's also a transformative professional opportunity for you as neurologists. I still remember when I trained in internal medicine, in the emergency room, we would take turns with the neurologist for stroke patients, because initially there wasn't really much you could do but manage complications and organize rehab or long-term care. So it wasn't particularly attractive to admit these patients. They would just tie up your beds and you couldn't do much. Even in my training, thrombolysis for stroke became available, and all of a sudden people couldn't get to the ER fast enough to grab the stroke patients. Even the radiologists tried to get a piece of the action. So with availability of treatment, practices and practice patterns tend to reform dramatically and also attract a lot more talent into the profession. And you've seen this in specialties like dermatology, in GI and immunology, which were to some degree pretty quiet practices and have now evolved to high-tech, high-scale enterprises. And last but least, there's a civil duty to handle dementia and Alzheimer's disease. We owe this to our parents and grandparents who are facing, like my mother, this terrible disease with no option to treat at the moment. And we also owe it to our children for the sustainability of our social protection schemes that are under pressure today and will become under more pressure as the populations continue to age. Well, that ends our discussion for today. I hope you found it informative and useful for your practice. Thank you very much for your attention.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peer Review Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/JGK860. This activity is supported by an educational grant from Biogen.